So thank you very much. I'm always happy to be number 2 to Norm, although it is a little humbling to have to follow him. So you'll notice the first thing is that I changed the title. After I heard what Norm was talking about, I decided we had to make this sort of a little bit more controversial. And so I'm going to talk about the role of ethics and ethicists in international case studies, and I'm going to argue for a reflective equilibrium approach, and I'll explain that as I go through it. So I want to examine 3 case studies, which means I have to talk 33% faster than Norm did. But anyway, so the first question is, how many people have ever heard of the neonatal sepsis research in Gadchiroli, India? Okay, so I see very few hands. How many know about the Haemophilus influenza B research that was done in the Gambia in the late 90s? More hands. Okay, and the last one is, how many know about the Bucharest Early Intervention Project in Romania? Okay, so these are not well known to people who are interested in bioethics, and that's going to be an important point as we go through these 3 cases. I want to look at 3 ethical concerns. I want to look at the standard of care debate, which Norm has beautifully covered. I want to look at the equipoise debate, which relates to the standard of care debate, and I want to look at data safety monitoring committees as well as stopping rules. And I want to ask 3 questions. Could the study be done in the US, and does it matter? What role did ethicists play in the study's evaluation, and what lessons can we learn? So let me start then with the standard of care debate, just go through the 3 issues that we're going to be dealing with from the ethics perspective. As Norm pointed out, the Declaration of Helsinki is very clear that in any medical study, every patient must be assured of the best proven diagnostic and therapeutic methods. There is a clarification in Article 29, which allows placebos, but in very limited circumstances, and would not fit for either the cases that Norm used, nor in the cases that I'll be presenting today. The CIOMS, actually, which is another set of human subjects protection regulations internationally, actually does allow for more wiggle room. It says another reason that may be advanced for proposing a placebo-controlled trial is that using an established effective intervention as the control would not produce scientifically reliable data relevant to the country in which the trial is to be conducted. And Norm showed that very beautifully in the HIV studies. They also then wrote, one reason could be that the disease or condition manifests itself differently in different populations, or other uncontrolled factors such as nutrition, malaria, and things of that sort, as we find in the HIV trials. So that's one issue. The second issue that I want to be thinking about is equipoise. Charles Fried brought this up in the concept of individual equipoise, which means that any individual clinician researcher is uncertain as to which arm is going to be better, A or B. And Benjamin Friedman made that more general, saying it doesn't matter if any particular clinician researcher has equipoise. What really matters is that the community of clinician researchers have equipoise, so that at least whatever percentage, let's say 1/3 of the room thinks arm A and 2/3 think arm B, then it's still ethical to enroll your patient because clearly there's clinical equipoise. In contrast, Jason Karlowitz and John Lantos actually wanted to argue for a concept of community equipoise, which argues that you have to have uncertainty within both the medical community and the public. Bob Beach has sort of shown why that's probably unrealistic. But then we have Frank Miller and Steve Jaffe, who argue that equipoise is not always even necessary for clinical trials, and in a sense are using some of the same positions that we saw in the CIOMS, that even if there's not equipoise, overall it may be in particular circumstances that you don't need equipoise. The last concept, so the 3 are going to be standard of care debate, equipoise, and the third is going to be about data safety monitoring committees as well as stopping rules. So there's an agreement that clinical trials need to be monitored to ensure patient safety, and that at some point that the need for formal procedures to cover early stopping for safety reasons must be encouraged. And so when should you stop a trial? When conclusive evidence of harm has been established, or when the potential for harm exceeds an acceptable limit of comfort for an oversight body. So as we saw with the HIV, both the 076 trial as well as the short course versus placebo, many of those studies were stopped early because it was shown that the treatment arm was so much more effective than the control arm. But when should you have caution and have to think about and possibly, but not necessarily, stop a trial? when early alarms warn of possible harms, but the data are too preliminary. So one of the concerns, if you stop a study too early because you're seeing a trend, it may be that you're just seeing a trend, and that if you continued to study further, that trend would be disproven. So you don't want to stop too early, you don't want to wait too long, because then you're doing harm. You got to be in the Goldilocks position of just right. But one question that we're going to ask in these three cases, at least in the third case, is there ever a reason to continue once equipoise has been disturbed? So to go beyond, even though you already know that arm A is better than arm B. So let me now look at the three cases. This first case is known for the area in which it took place, in Gadchiroli, Maharashtra, and I apologize, I'm sure I'm pronouncing this awfully, India, and it was based on a home-based neonatal care project that was organized by Dr. Bang and his wife, and they had created an organization in the late 1980s called SEARCH, or the Society for Education, Action, and Research in Community Health, which was an NGO set up involving actually 100 villages, and in that area they have trained and supported male village health workers, as well as traditional birth attendants, as well as doing some treatment in the clinical management of pneumonia in children. They've actually offered other health resources and reproductive health, and they've actually been an incredible resource to this area where they both practice and do research. And in 1993, SEARCH found that the local neonatal mortality rate for the villages it served was around 60 per 1,000, and that, just to give you an idea, compares to 5 in 1,000 in the US. They found that 95% of deliveries occurred in the home despite the relative proximity of public health care facilities, and that household surveys found that over half of newborns needed some kind of help, but that less than 3% received professional medical attention. Now, in India, in 1993, it was clear the guidelines for a sick neonate was hospitalize immediately if the child looks ill, IV for fluids, as well as antibiotic. Dr. Bang, who was working in this area, said the standard of care meant let them die because the parents didn't bring the children to the hospital. And just to give you an idea, in 2009, still over a quarter of the annual global newborn deaths, over 1 million per year, occur in India. And despite some improvement, their neonatal mortality rate is still at 43 to 1,000. So in 1993, SEARCH decided they were going to do this ongoing child health program. They had these two areas. They had an active arm approach where they had been conducting research in the area, and there were 47 control villages where they were actually collecting epidemiological research, but they actually didn't put a lot of resources into those 43. This was just picked because of access. All the 43 weren't sort of left out to dry. They actually had government health care services, but they offered some additional services in these 53 action villages. And one of the things to note about these 100 villages is they actually were very similar geographically, economically, and socially. And so what the SEARCH group did was they developed this home-based neonatal care, so that if a child was born who looked sick, that they would train female healthcare workers who would then go to the house. First line was to tell them you should go to the hospital when the parents refused. Then they were going to offer them some home-based sepsis treatment with oral antibiotics, as well as one dose of an IM antibiotic, which was known to be substandard. So that was going to be the active control arm, right? Everybody knew the standard of care in India was hospitalized and IV antibiotics. Interestingly, of the 53 villages, which they called their action area, they got community consent for this project. They trained women who had at least 5 to 10 years of schooling, and they were only able to do that in 39 of the 53 villages because in 14 villages, the population was either too small or there was no appropriate woman to train to be a female healthcare worker, meaning that none of the women in the community had at least 5 years of schooling. And then in these areas, how they did the research was they spent 5 years. In the first 2 years, they collect epidemiological research from both the active arm and the control arm area, and then they started training. So the first thing was they had to get the families to actually accept having a female healthcare worker come in, and then in the second year, they started getting more involved, and then finally in the third year, they even went beyond just doing this sepsis treatment. They were also doing education of pregnant women and grandmothers about breastfeeding and about other minor health care issues that they should be taken care of at home. So even their intervention still left these families at substandard health care. And they made no referral apart from what was already available at government hospitals, although every family was told in the consent process and in the community consent process that they were free to seek care from other sources. In the control cluster, SEARCH did not provide any training. In fact, they didn't observe any home births. All they did was collect, in a sense, birth and death records from the community. But it's not exactly a placebo arm, as Bang has subsequently argued, because in some ways he could say that prior to collecting the data, there were numerous health interventions given at the village level that were being done by the government healthcare workers. It's just these additional resources were only being offered in their active arm. But they got no consent for this because all they were collecting were epidemiological data, how many children were born this week, how many children died. So the study design was what we call a cluster non-randomized. He picked the arms where he already had his resources and staff in place. The argument that he gave was that the clusters could not randomize individuals, as it would have placed the female health workers in an ethically problematic situation. They were of low health literacy, trained to actually provide resources when the child met the criteria they had been taught, and to ask them to sometimes withhold it they didn't feel that they would do. They also did non-randomized because they realized that if they did two communities and the women heard about what was going on, that women would just move from one community to the other in order to get these additional resources. So they selected them en bloc. And yet, as they said, while there were biases, these were all, in a sense, at least at the introductory phase, that all of these communities looked very similar. So one question that everyone has to ask is, was it ethical not to offer any interventions to the control units, given that a known treatment existed? Well, remember what the known treatment is. The known treatment is go to the hospital and get IV antibiotics. And that was actually offered to everyone. The fact that less than 3% of parents did it, again, like Norm has said, really wasn't the responsibility of the researchers. But remember then what the trial is offering is substandard. And so what actually happened, they published their data in 1999, and they demonstrated with their substandard treatment that they got a 62% decline in neonatal mortality rate in rural communities using this home-based neonatal care approach. They published it in The Lancet. In 2001, they gave some more data in a journal called Indian Pediatrics, where they described the burdens of morbidity among neonates in these communities. And in 2005, they actually got an entire supplement of the Journal of Perinatology, where they went through this study in really elaborate detail. So that's where we are in 2005. But you should know, from an ethics perspective, the only mention of this study was in 2002, that there was a discussion of ethical research in the international community, and Dr. Buddha, who is the chair of pediatrics and child health in Pakistan, actually wrote in support of this study, thinking that it was very much an ethical research. But in 2007, Ethical Issues in the International Biomedical Research, a casebook, was published by many of the NIH ethicists, Lavery, Grady, Wall, and Emanuel. And in it, they included a description of the study that I just gave you. They asked Dr. Buddha, who defended the study, and then they had Marcia Angell, who we've already heard her opinion about the HIV studies. She also was asked, and she was very seriously criticizing this study. Interestingly, the book gets reviewed in The Lancet, the same journal where the original study was published, where they criticized the use of this case without fully understanding the context, and sort of saying, ethicists, if you're going to use studies, you really need to understand the facts. A debate then ensued, because that was the only way that people even in India even knew that this study was being criticized. And between 2009 and 2011, a number of articles discussing the ethics were published in the journal called the Indian Journal of Medical Ethics. Nothing ever again appears in the American literature or the British literature. So what were Angell's criticisms? She criticized the science because it was non-randomized. She criticized the need for the study because she said, quote, "We know the standard of care." She criticized the study design, withholding effective treatment from the control group. She suggested a study that would have compared outcomes from female health workers and more highly trained medical personnel. Again, a resource issue that was obviously not realizable in this community. And then she accused the researchers of self-interest. She said there is knee-jerk tendency to respond to the lack of medical services with clinical trials. Partly this is a matter of researchers responding by doing what they know how and are paid to do. So really accusing them of self-interest and conflict of interest, and she accused the researchers of exploiting the poor. So Angell's criticisms, first of all, ignores the fact the study was approved by National Ethical Review process of the Indian Academy of Pediatrics, was locally developed. This isn't like the Americans were coming in and imposing this research. It was developed by Indians for Indians. The trial was actually part of a national priority setting mechanism. The protocol was developed with full community consent and participation. It did fail to provide acknowledged standard of care, but it also realized that that was not feasible and not sustainable. And it did not have government commitment to implement. So one of the interesting things was that Angell also said, well, maybe it would have made sense to do this type of research if you knew the government was then going to implement all of this. So Dr. Bang, and sort of denying the fact that we did see this huge decrease in mortality, and that despite the fact that the study ended, that Bang was able to get resources in order to maintain the female health workers and this whole process for many years after the study had been completed. And in fact, as Bang wrote, he and his wife, we have strived to influence policy at state and national levels to incorporate home-based newborn care in rural areas. We have done this by including publications in medical journals, by using the media, by judicial activism and political lobbying. In fact, they had the Mumbai High Court initiated public interest litigation, citing our 13-site study report on child mortality. This was a court case that's saying that the Indian government wasn't doing enough to protect its own children, and the High Court ordered the government to introduce the Gadchiroli model of newborn and child care in 5 districts that were even worse off than the ones that Dr. Bang had been working in. And to the criticism of the fact that he had conflict of interest, he likes to point out he continues to live and strive in Gadchiroli, trying to help the community that he serves. So here was one of those cases where the ethicist sort of looked over. Oh, wait, my references were left out. But in your handout, you'll see that there are references, and what's really interesting about this study is that there's, well, you can take a look at some of the essays which look at it, but it's really, in my mind, a sad commentary that we're making comments without having all the medical facts. And I think we're going to see that in a lot of our international studies, that it's easy to criticize until you really go down and see what they're doing. So no, nobody got standard of care, and yet we did get a 2/3 decrease in mortality. In the next study, we have placebo-controlled trials of the Hib vaccine for the prevention of pneumonia in the Gambia. Just want to thank Skip Nelson for pointing this case to me. The background is that they actually had done a surveillance study of Hib back in August 85 to 87, and they found that Hib meningitis was more frequent in the Gambia than in industrialized countries, and it also affected younger children, which, if you were going to implement a vaccine, would be important to know both when you need to be vaccinating. And they had actually a case fatality rate in the Gambia of about 30%. Hib pneumonia was also much more common in the Gambia, but it was difficult to diagnose because it's very insensitive to blood cultures, and the way they were able to diagnose it during their surveillance study was pretty aggressively to actually do lung biopsies. And at that time, they thought that Hib caused about 7% of pneumonia. As we'll see throughout the study, it probably caused about 25% of the serious pneumonia leading to hospitalization in the Gambia. One of the interesting things that they learned from this background study was that the epidemiology of Hib disease is different, that it's mainly pneumonia in the developing world compared to meningitis here in the US. But one of the things is that unlike meningitis, Hib pneumonia can result from direct spread, so it was actually not known how effective the Hib vaccine would be in preventing pneumonia. It was really, in a sense, when the studies were done here in the US and in the Western world, really the focus was, can we prevent meningitis? So, since 1989, as Hib vaccine has been available and known to be efficacious in Europe and North America for the prevention of meningitis. And as I mentioned, it not known if it would be effective against pneumonia. So, in the Gambia, they decided to start placebo-controlled trials of Hib vaccine in 1993. And so, again, the question comes, well, we already have a standard of care. How can we be doing it? And the answer was, in part, that they were going to argue the ethics of it that one, we didn't know how effective it would be in different populations, and number two, again, because you were going to have to change the timing of the dosage because of when the kids got sick. Interestingly, the U.S. government, because it was funding the study, did get involved and was very adamant about the consent issues. And I'm really going to leave that aside, although in the references for this, you'll see that they actually did a whole study about the consent issues, which is actually quite interesting. But I'm going to skip that for the purposes of this talk. They also, though, had a data safety monitoring committee. There were two international bodies who oversaw the trial. One was a 4-person steering committee with 2 international experts, representatives of the funding agency and a representative of the Gambian government. And then they also had a 2-person safety monitoring group. And so here was their study. 42,800 Gambian infants were either, when they presented for their first DTP, yes, not DTaP, not acellular pertussis, too expensive, for their first DTP vaccine at 20 health centers in a certain region, they were either randomized to get DTP or DTP Hib. The vaccine was meant to be given at 2, 3, and 4 months, and what they were going to collect were cases of meningitis, pneumonia, and other invasive Hib diseases were going to be investigated at 23 hospitals, and pneumonia was going to be investigated at least at 2 hospitals where they had X-ray facilities. And the protocol said it was supposed to be given, as I said, at 8, 12, and 16 weeks. In practice, actually, the vaccine was more likely given at 11, 18, and 24 weeks, and 17% of the children failed to receive all 3 doses, which also tells us one thing, that when we think about how research is done in the international world, you know, it's a lot easier when everybody has cell phones and cars to be able to get to clinic appointments on exactly the right, within a 3-day window. Wasn't going to happen here as the study was being done. But as the study was going, they got interim data in February 1995. They've had 39 episodes of culture-proven invasive H flu disease, 12 cases in children who had received 3 doses of study drug, 6 Hib pneumonia in children who had received 2 or 3 doses of study drug, not knowing because they had not unblinded the study. So they actually had one DSMC member look at the data for the H flu pneumonia, because that's what they were most interested in. And they found that 5 of the cases were in the control arm, 1 in the study arm. And he told the team, we don't have adequate power regarding pneumonia. And so even though we had adequate proof in the meningitis arm, all the children who got meningitis were in the no Hib, in the placebo arm. So despite the fact that they had plenty of data to show that the H flu vaccine prevented meningitis, they said our goal is to prove that it prevents pneumonia. And the reason they needed to prove pneumonia was they said the Gambian government is not interested in funding this unless we can reduce the amount of pneumonia. So they recommended to continue the study. Again, so here's a real interesting issue about stopping. Should they have stopped when they reached a point where we would have stopped here in the United States? They continued, and when they actually finished in March of 1996, they actually now had 50 cases of invasive pneumonia, Hib disease, 17 pneumonia, 28 meningitis. Remember, they can only diagnose the pneumonia in the 2 hospitals with X-rays because of the insensitivity of the blood cultures. They also found 5 other Hib disease cases. Interestingly, the efficacy for those who had received 2 or 3 doses was actually 100%. Remember when I showed the slide, I said that 5 were in the vaccine arm and 1 were in the placebo arm and 1 was in the vaccine arm. It turned out that after they kept studying the result, it turned out that the 1 person who had gotten the Hib vaccine did have Hib, but a different form than was actually protected by the vaccine, and so he was excluded from analysis after the code was broken. Hib was also to be found much more common than the original data suggested. It was much closer to 20% versus 7%. So given that the vaccine was effective and given how important they were able to prove that the Hib disease was in the community, I'm going to skip this because that just goes how important it was. This was their finding, was the finding of a high degree of efficacy for the prevention of meningitis and pneumonia caused by Hib in African infants was expected by many. However, the significant impact on overall rates of severe pneumonia and the demonstration of the true contribution to Hib to the vaccine trial proved to be a very powerful instrument for the estimation of disease burden attributable to the pathogen. And what that led to was how now were we going to move from having this data to getting the vaccine available. Before I get to answering that question, I just want to say, so the 2 ethical questions that the case raised was it ethical to perform a placebo-controlled trial of Hib, when it was already standard of care in developed countries? And was it ethical to delay stopping the trial to determine the efficacy of the vaccine against pneumonia? And so at the time of the study, the Hib was known to be efficacious in Europe and North America, but it's actually interesting that first we know that the epidemiology of Hib was different in the Gambia, that they had much higher pneumonias than we do, and it wasn't clear whether the vaccine would be effective against pneumonia. But it also should be pointed out that studies here in the US found that the Hib vaccine was not efficacious in Alaskan natives. And therefore, because of possibly genetic reasons, the feeling was, how do we know it's actually even going to be at all effective in the Gambian population? And so that was another reason they justified doing a placebo, despite the fact it was known to be effective here. The researchers also argued that it was ethical because otherwise Gambia wasn't going to pay for it. And the government really wanted to know that it was effective against pneumonia. The stopping rules is interesting. When you look at all the literature of stopping rules, it's always about when should you stop early and don't stop too early, because you might be seeing a trend that's actually a false trend. And nothing is written about stopping late. And why not? Because the answer is it would mean that equipoise had already been disturbed, right? We knew this vaccine was effective for meningitis. It was effective for meningitis in the US. It was effective for meningitis in the Gambia. And so we would say, our ethics rules say, once you know that equipoise has been disturbed, stop the study. But they felt that had they stopped the study, they would have never gotten the support that they needed in order to be able to roll this out throughout the whole country in a resource-limited country. And since the completion of the trial, the Hib vaccine is now recommended for use in developing countries by the World Health Organization, although they didn't have, and that's a criticism that was made by ethicists, was that they did not have a promise that the vaccine would be made accessible to Gambia at the time. They had actually gone through this same experience in the Gambia for hepatitis B in a study in the mid-1980s, and were able to actually implement using hepatitis B because the price of the vaccine was much cheaper by the end of the study, although there were some gaps. And here, after a 17-month delay, they were able to get both help from a donation from industry as well as from other organizations in order to be able to get funding to have the Hib vaccine. And so the Gambia was the first of the developing world to get the Hib vaccine. It's now spread through much of Africa, but still there are parts that don't have it. I point out the references only to note that if you look, you'll see that the ethics has actually been mostly studied by the researchers themselves. The second article by Mulholland actually was an examination of all the ethical issues in the study. You'll also see the last study was by Leach et al. Because the US was so adamant about the consent process in this study, they decided to do a supplemental study about the consent process, which it's an interesting read, suggests that there was lots of misunderstandings, and yet some of those same misunderstandings about randomization and placebos we find in the US studies as well. The third case that I want to look at is the Bucharest Early Intervention Project, which is known as BEIP. It's the Romanian, also known as the Romanian Orphan Study, and this study was brought to my attention by a Hastings Center blog post by Joe Finns in October 2013. So just a historical overview. In 1966, when Ceausescu banned birth control and abortion, leaving many parents feeling the need to leave their children in state institutions, and so 23 years later, there were 170,000 children living in these facilities. Even after the dictator was overthrown, children were still being institutionalized through 2005. There had been some small descriptive studies of institutionalization in the West between 1940s and 1960s, which showed that institutionalized children did poorly. Actually, some of those studies impacted the way we organized and raised children in institutions here in the US. So there was concern then with this study that the children who were removed from institutions to foster care or adoption were less impaired, and so they wanted to do a randomized trial to look at whether children who were first placed in institutions, some of whom remained in the institutions versus those who went to foster care, who did better. And the US researchers, 3 of them, approached Romanian officials to study the adverse impact of early life in an orphanage. The project was launched in 2000, and the inclusion criteria were that infants abandoned to institutions, the infants had to be abandoned in the first weeks of life, and then they were enrolled if they were between 5 months to 31 months, having spent at least half of their life in an institution. They had to be evaluated to be free of neurological, genetic, and other birth defects, so that as they looked at development, they could argue that this was whether institutions versus foster care were better. So the randomization trial was to leave half the children in the orphanage and place half into foster care. They actually had a third arm. They took typically developing children who live with their families, never institutionalized. They did that in part to prove that all of the surveys and all the instruments that they were using got equivalent results in Romania as they did in the US children. And that was actually quite true, that all the children who were typically developing, who were living with biological families, did as well as US children on all the instruments they used. So they recruited 136 infants. Average age was 22 months. They studied them at 30 months, 40, and 52 months. They showed that the average IQ of the institutionalized children was lower. They found that the best results occurred if you placed children in foster care before 2 years of age. And as soon as these results became available, the findings were communicated to the Romanian government, and the study continued. In their second assessment done at 42 months, they found that the children in foster care displayed improvements in making emotional attachments. Again, looking at subsets, the children placed before 2 years of age did better than the older children. The research team stated clearly that they did not interfere with government decisions about changes in placement when children were either adopted, returned to biological parents, or later placed in government-sponsored foster care, which they point out didn't exist at the start of their study. And in fact, at 42-month assessment, less than half of the institutionalized children remained in the institutions. And so they collected their data then as an intention to treat, intending for these kids to remain in institutions. But there was a sea change going on even as the study was starting that people were questioning. And one of the things we have to remember is when we're talking about Romanian institutions, we're not just talking about orphanages. We're talking about, orphanages that were described by Dickens. I mean, there was a huge media when Ceausescu gets deposed and the U.S. media goes into some of these orphanages, the conditions were absolutely horrific. And so in a sense, one of the things we have to be thinking about is horrific orphanages do worse than Cadillac foster cares. And why do I call them Cadillac foster care? Because not only were these children placed into foster homes, but there was a social worker who worked with the foster care families, educating them about how to care for these children, offering them support groups, and things of that sort. And in fact, we'll look at the data as the study starts going away and as these children start going into Romanian foster care, the difference between those children who were left in the institutions for longer and the children who are in foster care becomes much smaller. So again, by 8 years, in fact, only half the children originally randomized to foster care was still in the BEIP Cadillac foster care. Many of them had already been moved to the Romanian foster care system. And as I mentioned, the data showed that the gains that they had compared to those children who were institutionalized were much smaller as they moved away from these Cadillac programs into what would now be offered in Romania. And more data keeps showing that the kids who were removed earlier did better. We got that. So here are the 7 questions that have to be asked about the study. Was the study design ethical? Did the study have social value? Or were the results already known as it was accused? Was there equipoise between the 2 arms of the study? Was there adequate ethical and regulatory protections in place? Was there a data safety monitoring committee? Right, at 2 years, we already knew that the children who had been removed from foster care were doing better than those in the orphanages, but there were no stopping rules as sort of the end point there, and so no changes were specifically made. Then we have to look at the question of what are the post-study obligations and what role did ethics play in the study. So first is the question of the ethics of methodology. Was it ethical to randomize children to remain in the Romanian institutions? And could the study be done in the U.S.? And the answer is clearly no. It was neither ethical, and no, it could not be done in the U.S. The Romanian institutions, which, as I said, were played out in the media for the U.S. in 1993, showed how horrible these facilities were. The researchers said, well, we don't want to fix the institutions because what we want to prove is that foster care is better than institutions. Well, but they're comparing apples and oranges because they're comparing an over-the-top foster care to one of the horrendous scenarios of Romanian orphanages. And so one question, was it ethical to do in Romania? And they wanted to argue yes, because Romanians were sort of divided about which would be better. But again, I don't think any Romanian was divided about whether an orphanage from Charles Dickens or an orphanage that could have been improved. I think the concern here was that we were creating a straw man by comparing anything to these horrific conditions that we allowed these children to remain in. There were two alternate study designs that could have easily been done. The first was enhanced institutional care. Bring them up to the standard that we already learned in the 40s through 60s from the data we collected from American orphanages of the need for children to be able to create, in a sense, a primary caregiver and to have emotional attachment and things of that sort. And so then we would have had, what does a good orphanage look like versus a good foster care system? And that's probably a much more important question, particularly, that's a much more important question. The other way of designing it was, since they were enrolling kids who had been there, they could have compared children who had been left in the orphanage, who had only been in there up to under a year of age, and those who had actually remained in the orphanage. If you remember, they were enrolling kids between 6 and 21 months of age. And what we know is that the younger you remove children from orphanages, the better they do. And so we could have used, in a sense, not left anybody in the horrible scenario, the horrible orphanages in which they were living. We could have just looked at who does better, and children who spent the first year of life in an orphanage versus those who spent much shorter periods of time. And we would have been able to prove that foster care was much better than if they were moved earlier. But that wasn't the study that was done, and the American researchers were defending their research. And so one of the big questions is, didn't we already know the results? We knew that children who lived in horrible institutional care did poorly. And Frank Miller, an ethicist from the NIH, actually says, critics might contend, since the answer to the research question was already known based on prior observational research, that there's no social value in conducting the research. And he disagreed. He said the research question is not asking whether foster care is superior to institutionalized care, but rather whether young children initially placed within institutions in Romania had better outcomes after transfer to foster care. And I would just want to tinker with that statement and say, and at what age should they have been removed? And if you go at what age did they benefit, then you could have had the second design study and didn't need to leave anybody in the institutions. The next question was, Miller said, even if some experts claim to know based on observational evidence or experience that a particular intervention is effective in producing a given outcome or is better than an alternative, positive results from a well-designed randomized trial may be necessary to persuade policymakers to change standard practice. So his point here was, even if it wasn't ethical to do it in the US, if this was the only way to convince the Romanian government that their orphanages were awful, then maybe that makes this study ethical. And again, I would point out, as Joe Finns did in his essay in the Hastings Center, those changes were already coming into effect at the time the study was being done. And so in a sense, we were answering a question that really was already known. So that raises the question of, were we in equipoise, right? So there were early data that showed that foster care was better than institutions. It's the data that these three American researchers showed. But they actually argued that none of the studies were done in randomized fashion, so they need to do a randomized study, otherwise we couldn't prove it to the Romanian government. And Xenia and colleagues argued, but the Romanians were divided about which was better, foster care or orphanages. And again, I would contest that while there might have been a question which is better, and it's a reasonable question to ask whether orphanages are better than foster care, clearly the worst orphanages are going to be worse than good or, in a sense, Cadillac-type foster care. So I don't think they were actually asking the question that really needed to be answered in the first place. The next issue was, did it have ethics and regulatory oversight? Interestingly, when we think about international research, we want research to be approved both in the US, if it's funded by the US, as well as in the country where it's being done. They didn't have any Romanian IRBs at the time. They did get approval by the local Commission on Child Protection in Bucharest, as well as by the Ministry of Health. The Romanian partners required that the study be conducted within the principles outlined by the UN Convention for the Rights of the Child, which is sort of a smack on our face since we're one of 3 countries that have not signed the Declaration of the Convention for the Rights of the Child. It's United States, Somalia, and South Sudan. We got permission from biological parents to place their children in foster care, and this does go into the fact that there was some degree of equipoise within the community in Romania about which would be better, placing your child in foster care or leaving them in an institution. There was no DSMB and no stopping rule, so even after they found, after their first data collection, that children who had been removed from the orphanages did much better, they didn't, in a sense, stop the trial and move all the children into foster care. They decided they would just keep collecting data. So what about post-trial obligations and benefits? After the early data showed that children do better, what obligations? There were no stopping rules, and so nothing was really done. Now, to the researchers' credit, they point out that no child that they put into foster care was ever placed back into an orphanage. Some of them were placed into state-run Romanian foster care, which, as I pointed out, really didn't do well, or not nearly as well as those children who were in the BEIP foster care system. The researchers claim that the foster care system was catalyzed by their study, although Joe Fins has pointed out correctly that the changes had begun before even their first data were collected. And again, I'm just going to keep harping on this. I found the study really unethical, but for different reasons than Fins did, because we really didn't have 2 arms that really were addressing the issue for the Romanian government. If the Romanian government really wanted to know, could we maintain foster orphanages, the question is clearly not the orphanages from the Ceausescu era. We really needed to look at what would be high-quality orphanages. And so I put in here 3 pages of timeline so that you can see that although Fins points out like this was his moment, his Reverby moment, that he discovered a problem that nobody had been thinking about, it turns out that with every single publication, an ethicist or somebody was asked to comment on the ethics of this study. And it went on and on over the whole course that the study was being done. After reading this whole debate then, realizing that ethicists had been commenting and were not outraged like Fins was, one of the questions I asked myself was, I went and reviewed the data about abandoned children. And here are some facts that never get published in any of those articles, which, first of all, there are 143 million orphans and millions more abandoned children worldwide. And so the idea that maybe that we can actually create 143 million foster care systems might not be realistic. We have 53,000 children who have just come across the border, as Norm reminded me this morning, and we're talking about whether we're going to be placing them in foster care or orphanages as well. Orphanages are still actually quite common around the world, and their outcomes are often as good, if not better, than foster care. And that's a surprising data. I point out there's an article by Wetton and al., which was done in 2009, and the researchers themselves said, we were surprised to find this, but that what they found was that in communities in which orphanages were designed to create continuity of care and to have children create, in a sense, a primary caregiver, that they actually had quite good results. And then there are some data from Richard McKenzie here in the US, which talks about after the 40s and 50s and the horrific stories about orphanages as we improved our own orphanages here in the United States, how successful some of these orphanages were as well. So this primary assumption that was made that orphanages are always terrible, yeah, when you go to a Dickens-type orphanage in Romania, they are, but maybe we need to look around the world and to see how it could have been done better. So I think that the study, this one was unethical in contrast to the first 2 studies, where I think that despite the fact that we didn't meet standard of care, that we might have failed to act after we hit equipoise, totally legitimate, and I think that we need to be thinking about the fact that we're asking different questions when we do international research ethics. So in summary, the Gadchiroli and search studies, we've actually, when you think about post-research success, the home-based neonatal care is now standard of care in rural areas, despite the fact that it's actually below the, quote, national standard of care, which still remains IV antibiotics and hospitalization. The Gambia Hib study did lead to funding by Gavi, not just for the Gambia, but throughout the developing world, and the Romanian BEIP studies showed that foster care is better than institutions, well, at least Cadillac foster care to bad institutions. But one of their biggest ethical problems with the design was that they failed to minimize harms. They either had to remove all the children and just do it on a time basis, or if they weren't going to remove all the children, they had to improve those institutions, which really were horrific. So one of my final comments is that why has there been so little discussion of these issues, cases in mainstream U.S. ethics circles? And one thought is this notion of called hidden research ethics by Jim Dubois. And he says, how are cases hidden? One, if they're not published in a journal that ethicists read regularly. If they don't include keywords that would get us to actually skim those articles, if we just got a table of contents from many of our journals. And when the authors of the study themselves either do not recognize or do not explicitly discuss the ethical significance of their findings. To the credit of all these international researchers, they were discussing the ethics of it, but then the US researchers came in with a holier-than-thou approach that we have the shibboleth, as Norm presented in the first set of lectures, and therefore condemned all three of these sets of studies. Rather, I think when we think about international research, we need to think about it in a concept of reflective equilibrium, which would be a bidirectional examination of case studies and ethics principles. Are ethics principles and how are they fitting with this ethics case? I think Norm is right that the ethics principles are the same, but some of the differences that we're seeing is we actually have different contexts, but we're also in a sense then asking different questions because of the resource limitations that the researchers really aren't responsible for. And so, thank you very much.